Okay, hi everybody. BJ Miller here, palliative care physician. So we're here to answer questions that we didn't get to in our caregiving webinar, and there are a handful of them, or more than a handful of them. So I'm gonna try to be crisper in my answers. Okay, so take it away, Sonia.
Okay, great. So the first question is a little bit of a long one, so I'll read the whole thing here. She is an OT working in acute and inpatient rehab, and she's also the primary caregiver for her mother who has end-stage COPD. She's also an only child. Her father recently tested positive for COVID. Fortunately, his main symptoms were cognitive impairment, which is cleared for the most part, and he did not require hospital admission. However, during all this time, she noticed how often she is bracing for impact. So throughout her mother's extended illness over the years and her father's varying health, she doesn't think it ever occurred to her how this affects her and the way she is able to show up for her loved ones. And she doesn't think that being a health professional helps in these moments, as she thinks that seeing the worst case scenarios can't help but make her think of these situations with her own family. So she's thinking about keeping your knees bent and remaining flexible, and letting go might actually allow her to be more present and available. And she's wondering how palliative care may support the caregiver and the family unit and all of that. And a quick note, I'm hoping, BJ, you can define COPD and OT in your answer as well.
Okay, so let's break this down. So first of all, thanks for that question. There's a lot in there, so let's see if we can break it down. So first of all, OT stands for occupational therapist. So occupational therapist is a little bit similar to physical therapy. You'll often see PT/OT departments, and some folks have training in both physical therapy and occupational therapy. Occupational therapy tends to be more of the mind-body connection, cognitive, languaging, communication, fine motor movements, etc. So occupational therapy is a very important piece of the rehabilitation world. So beautiful. I love OTs. I've benefited mightily from you folks over the years myself. So thank you. Oh, and then COPD stands for chronic obstructive pulmonary disease. COPD is a disorder of the lungs, a chronic illness of the lungs, not curable, but manageable. People can live with COPD for years. It's not uncommon as a fallout from prolonged smoking or exposure to toxins, but there are other reasons too. Non-smokers get COPD as well. And the way it's experienced is a shortness of breath. And so sometimes folks with COPD at the end or later stages will be on oxygen. And you may have seen folks walking around with oxygen tanks and the little nasal prongs. So that's COPD. Okay.
And then let me just refresh you on the question here.
Sure.
So thanks. She's thinking, she's talking about bracing for impact and kind of keeping your knees bent and being flexible, and how that mindset of being flexible and letting go might actually help her be more present and available. And then on top of that thought, wondering how palliative care can support the caregiver and the family unit in all that.
So let's start the second part. So yes, so palliative care, reminder, palliative care is interdisciplinary care. It's concerned around quality of life for the patient and caregiver. If you look up the definition of palliative care, it says the unit of care, excuse the lame language, but the unit of care, the subject of the care in palliative care is always the patient and family, or patient and caregiver, patients and friends, the inner circle of the patient. Because we know that people don't experience these things in a vacuum. We are affected and we affect our inner circle. And so you're all a piece of the puzzle as far as palliative care is concerned. So technically, as a caregiver or family member or friend who's close in, you should have just as much access to palliative care as your patient person does. Practically speaking, that's not the way it goes so easily because of insurance designation. How do you schedule an appointment as a caregiver and how does that get billed, et cetera? So it can get a little wonky. But know that at least in the philosophy of palliative care, caregivers are expressly part of the puzzle, not an aside, front and center piece of the puzzle. I'll remind you, you might not find a palliative care program that you could have in your local clinic that have a visit with. Maybe you could, it's worth asking. But you're always welcome to us at Mettle Health. And I mean this not as a plug for Mettle Health, but just to say the bulk of our clients are actually caregivers. And because there's no need to go through insurance or a doctor's referral, you can sidestep the logistics of the healthcare system. So anyway, sorry, long-winded, but that all important to get out there. So now back to I think the meat of your question. I think to me, I hear that as a question about vigilance. And so much of the role of a caregiver is to be vigilant, is to keep an eye on things, keep an eye on your person, on the home, on the set and setting. Are there carpets that a person can trip over? Is the lighting out? All sorts of ways you have to have a certain, you have to be sensitized to the needs of another person. That's an important piece of the job. Problem is, over time, in the chronic state, months, weeks, months, years, we can't stay in a hypervigilant state. Hypervigilant state is an acute kind of crisis mode state. And for between your work and your family life, I can imagine the need or the habit of staying vigilant all the time. Problem is that hurts you over time. You just kind of can't keep up that crisis energy. So to your point, yes, maybe ironically or paradoxically, oftentimes, one of the most important things we can do on behalf of another person is let go, is relax. So learning how to wind out of that vigilant state is really, really key. I think we talk a lot about how we wind into caring for another person, how we marshal the energy to get up for it, whether we're a patient or a caregiver, to deal with illness. But we don't talk about how important it is to wind out of that. So where there's a break, where you actually, maybe where you even feel good, you need to let that in too. That's where we get filled up. That's very, very key. That's where perspective comes in. That's where we refill our own tanks, etc. So yes, keep an eye on things, and at the same time, learn how to let go, learn how to relax. Relaxing is an active stance. You got to drop the vigilance. And I keep in mind also, no matter what you do, especially in chronic and terminal illness, things are going to go downhill by some definition, one way or another, no matter how exquisite a job you do as a caregiver. So part of this vigilance thing is to decouple your sense of success as a caregiver from the condition of your person. They're not necessarily linked. Even if you do everything right, that person's still going to get sick, or that person's still going to die at some point. So anyway, lots to say here. It's a balancing act one day to the next, but keeping your knees bent and flexible, I think, is so much the name of the game. Okay, thank you for that good question.
Okay, next question is, can you talk a little bit about the support that a hospice team provides and what they don't do?
So right on. So the hospice is an amazing, wonderful service. So lots to say about hospice. It goes back to the 70s in this country. The Medicare hospice benefit came online in the 1980s. And it's a very special, it was and relatively still unique in healthcare as a bundled suite of services. So with hospice, not only do you get the medical support of a doctor, but you get a nurse, you get a social worker, you get a chaplain, the volunteers. Hospice programs will often have things like art therapy, music thanatology, speech therapy, PT, OT, like we were saying earlier, physical therapy, occupational therapy. There's a large family of people, of professionals that can help support a person and their family. And it takes that much work. So hospice is a way to get this interdisciplinary mode of care. The expertise is around helping you and your family feel as well as possible. So symptom management, communication expertise, making difficult decisions, supporting your family through the dying process into the grief process. All of that falls squarely in the hospice mode. And the great thing is, in this country, you can guarantee yourself hospice as long as you qualify. You have to have 2 doctors to say you have 6 months or less to live should nature run its course. So if you qualify, hospice is bar none the way to get the most services into your home. Most hospice care takes place in a person's home. So it's a wonderful thing. But it's still inadequate. So one thing to clarify here is with hospice here, you get 24-hour a day telephone support. Something goes on in the middle of the night, you can call the number, you can actually speak to somebody. You have this big team checking in on you. But the average routine is, a nurse, so doctor in the background, nurse coming out a few times a week, and social worker or chaplain as needed. Maybe a home health aide for an hour or so a day to help with daily sort of caregiving needs. But that still leaves 20 plus hours any one day without the hospice in the home with you. So still a lot of work falls to the family and friends and the patient themselves. So keep that in mind. So hospice is amazing, the most comprehensive suite of services you can get into the home, but by itself, it's oftentimes not enough. There's still going to need to be work for family, friends, and patient. Okay, I think that answers the question.
Okay. Next up is, what types of questions or concerns do you hear from caregivers?
What types of questions or concerns do I hear from caregivers? Was that the question?
Yep.
Just broadly speaking?
Yeah, I think so. Just maybe themes.
Well, I think so. What I hear from at Mettle, what I hear from when caregivers reach out, very often it has to do with sort of the basics of caregiving. What do I do? My husband, my wife, my loved one, whatever it is, my neighbor, whatever it is, I is in need, and now I'm being summoned to help. How do I do it? So some of it is some of the questions that come up are, what are the mechanics of it? So like we talked about today, the activities of daily living, the tasks. But what's not quite so obvious are the sort of emotional attunement that needs to happen to be there for someone in a thorough way. And also another big piece of this puzzle is bearing witness, just not doing anything, but being there with someone to see their life play out, in a way to validate that person's life by witnessing. It's a primal, beautiful thing. So those are so much of the modes of caregiver. And so people ask me oftentimes how to do those things. But oftentimes it comes back to self-care. How do I take care of myself while doing these other things too? That's often a big piece of this picture. Pushing back on burnout and compassion fatigue, and how do you stay engaged and full of love, etc. And then lastly, I'd say a big thing that comes up is what to do when the caregiver and the patient feel differently about a situation. So it's really common that people will stay close together, good communication, checking in with each other, and the patient's wishes sort of tend to rule the roost, as it should. And oftentimes people find a way to stay close throughout it all. But it's really common that differences of opinion crop up. So a caregiver might want a family member to take on this or that kind of treatment, but the patient, left to their own devices, doesn't feel up to it, doesn't necessarily want to, or vice versa. That's pretty darn common. So as a caregiver, what do we do when we think the right way forward for the patient is different from what the patient thinks? That is a typical situation. Name of the game there is talking it through. And as a caregiver, being really clear about yourself. What are my projections onto this person? In what way am I meant to be there for this person on their terms? Versus what am I projecting onto them? Ultimately, it needs to be about the patient's wishes. But patients don't make decisions in a vacuum. We affect each other. So it's true too that caregivers' feelings, opinions deserve to be in the conversation. So back to exquisite communication, and that's what we spend a lot of time on.
Next question. I think we touch on this, quite often, but it's an important one that bears repeating. And it is, can you talk a little bit about self-care for caregivers, and why is this important?
So self-care for caregivers is the thing that get in your mind right from the start is that this is happening to you too. Just because you don't have the illness doesn't mean you're not affected by it. So elevating your voice, your feelings, your thoughts into the mix. It's not an inherently subservient role per se. It is a role of service, of course, but that doesn't mean you have no opinions or feelings or thoughts of your own. Those need breath too. Think of illness as happening it happens to a team, it happens to a family. each person having their own experience along with this big shared experience. So you just have to get your head around it. There's a phrase in this world of caregiving called pathological altruism, which we've talked about before, which basically this idea that sometimes a lot of us absorb this notion that to be a good caregiver, I should have no needs of my own. That would be selfish. I need to be there wholly for the person. I just need to completely empty myself on behalf of this person. And that's a sort of poetic and romantic notion, but it doesn't work for very long because you're a human being. So even if you're there to be altruistic, even if you're there to just show your love for this person, even if you want the patient to be in the center of the mix at all times, you still need to care for yourself, because if you're empty, if you're toast, you're not going to be able to be very good to that person you're so devoted to. So even the most selfless among us need to tend to ourselves as part of this mix. It's not just what we do with people, but the quality of our presence, the way we can sit with somebody. So our bodies, our lives as caregivers are part of what we're bringing to the mix. So we need to tend to them. So that's the sort of justification of self-care if we need it. And then the last thing to say about self-care, it's not just time out for yourself. It may include that, but it's also looking to get what you need from the relationship itself, the caregiver-patient dynamic. You need to receive from that too. So sometimes that means asking your person for something, for time off, respite, for love, for affection, for more communication. Very often I'm coaching people how to ask caregivers how to ask what they need from the patient. So there you go.
Okay, great. Next question. Can you please talk about helpful ways to bear witness to someone's experience? Living with someone with chronic illness and being the closest, most consistent witness, but still not being in my partner's shoes. How can we help someone feel seen and understood when so many others shy away from their pain and suffering?
Beautiful question. Bearing witness is, like we've said, is one of the most important pieces of this puzzle. One of the most important things any of us can do for one another is actually to see each other, drop the judgments, not put lipstick on a pig or whatever that phrase is, not doll you up, not squint, but fully see you, warts and all, whatever you are, seeing you, not judging you, being with you. So first of all, just that's what we mean by bearing witness. And again, the muscle is being, not doing. The muscle is actually daring to sit there and look and not run away, and to get past our own defenses, our own fears, so that we can be fully open to what's in front of us. That's where the caregiving can be so enriching, is exercising that muscle of how to see, of how to be in the world. And on the receiving end, boy, I hope we all, before any of us dies, I hope we have a moment where someone sees us for who we are and accepts us for who we are. It is a magnificent kindness service. I think that answers the question. But I guess how to do that, I suppose, very simply put, the most simply put is don't run away. I don't mean just physically, just stay at the person's side. You got to leave. You got to do other things. But emotionally, don't cut yourself off. Don't numb out. Don't deaden the connection. Actually seek the connection, even if it's uncomfortable. That's what I mean by not running away. Non-abandonment is actually so much of the trick. And that means exercising the muscle of sitting with discomfort, sitting with suffering you can't change, either your own or the other person. And I suppose en route to this is where a lot of people find benefit in a meditation practice of learning how just to sit with their feelings, not trying to fix them all the time. There you go.
Okay, next question. How can a caregiver separate themselves from those feelings of success or failure based on patient progress or lack thereof?
So key. So like we've said, caregiving for someone who's temporarily sick or going through something that they're going to recover from, that's different. That's whether it's a few days or weeks or whatever, is being with someone, kind of holding the shoreline for them, because in some real ways they're going to go through this thing and they're going to get back to this idea of health and a full life in front of them and indefinite lifespan. In the realm of chronic illness, i.e. chronic illness being illness that isn't curable, isn't fixable, isn't going away. Um, that's different. That's not something you kind of hold your breath through and the person gets back to where they were before the event. Chronic illness, terminal illness, progressive illness, these are all phrases that mean it's not going to be fixed. Maybe you can manage the illness for some time, but at some point it's going to take your life. So it's very different. So being with someone over time in the chronic illness, where no matter what, so the key, one of the keys here is chronic progressive terminal illnesses, you know things are going to get worse no matter what you do. So really, you got to really note that, because otherwise, like your question applies, to say, am I doing a good job as a caregiver? Well, I might want to look at the person I'm caring for. Are they getting better? Well, then I'm doing a good job. Are they getting worse? And I'm not doing such a good job. That's the temptation for that to be the sort of evaluative mode. But you can't do that here. That's hazardous. You will link yourself. You will feel unnecessarily horrible. So the rubric here is: are you doing what you can? Are you asking the right questions? Are you thinking through things? Are you showing up for your person? Are you advocating for them best as possible? Once you can convince yourself that you're doing those things, that you got to leave it at that. There may not be any external gauge for satisfaction to this work. And it's really, really key that you master that, because otherwise, again, you're going to suffer more than you need to as you watch someone decline. And you're going to take things personally that can't be taken personally. So here again, one of the muscles of being a good caregiver, especially through chronic and progressive illness, is there a lot of self-awareness. Internally, you have to be your own gauge of success, failure to a large degree. And then also just talking to people, talking to the doctor, the medical team, the nurse. Am I missing something here? Is there something else you're seeing? Checking in that way to make sure there's no blind spots. Once you've done those things, it will be what it's going to be. And your job is to sit there and not run away.
Okay. Next one is more about terminology. And it says, I've heard the word care partner as opposed to caregiver lately. Is there a difference? I was caregiver for my mom, but from another state. While she dealt with stage 4 lung cancer, I was researching and helping find all the best treatments, clinical trials, triaging side effects, setting up appointments, coordinating insurance, but not day-to-day tasks. What is the best term for this type of work?
Yeah, language matters. And the language is so clunky around all this stuff: disability, illness, suffering, invalid. I mean, there's all sorts of words that are very problematic in this mix. Caregiving is problematic in that it's, as we talked, it's also care receiving. Good caregiving means good care receiving. Those are linked. So that word's imperfect. Caretaking always reminds me of undertaker. So like taking care seems odd. So I don't use that one. Frankly, I've never heard of care partner. I've heard the word carer. I've heard of my friends in the UK use that instead of a caregiver, they're a carer, one who cares. But care partner, that sounds good to me. I suppose that could mean anything, because really that is descriptive. Really, what's happening very often is you're not caring at someone, you are sidling up to them and caring with them. You're fastening your lives together and caring together. And in this real way, you are partnering with someone to care about one another, etc. So I love that phrase. And I'm just guessing that that's what it implies. And to my mind, if that's the case, then it's always relevant. You can swap that anytime you see caregiver. You can swap in care partner. I like that, but I should say I've not heard that phrase, and I may be missing a cue. I would say find the word that registers for you. A lot of people's caregiver just sounds like a task-oriented thing. I love my person. I'm not here as their caregiver. I'm their friend. I'm their lover. I'm their whatever else. Find the word that resonates for you. The bottom line is you're sidling up to someone, partnering with them, caring for them, receiving their care too. That's what you're signing up for.
Okay, great. All right, next question. My question is regarding my best friend who I'm caring for on a daily basis. She is dying and in really bad shape. Her daughter is 12 and very scared and sad. Her daughter has asked that she spend more time with her dad because being with her mom is too frightening. My friend wants her daughter to be with her more, but I can tell that this creates severe anxiety for her daughter, and I'm afraid that this might be traumatizing for her. Do you have any advice for what I can do?
Yeah, great question. It's so tricky. So the question about a family here where a young kid, almost teen, 12-year-old, um, I'm just sort of refashioning the question in my mind. So in general, so childhood development, that is something we're learning. It's laden with theory, and our ideas of what constitutes appropriate childhood development changes with time. But these days, in the Western mindset anyway, um, a lot of developmental issues, and talking with kids about serious illness and death, a lot of it has to do with deferring to the child, reading the child, not forcing them into a situation, but reading them in real time, pushing them, encouraging them to participate where you can so that they feel included, but also noting when they're overwhelmed and where they may be traumatizing. So some amount of deference to the child's position and what they're seeking is really important in this mix. It's also very important to not euphemize things too much, half-truth things. This is a way we can make things scarier for kids. The phrases like, "Whoa, grandma's going to a better place" often comes up. Well, kids might read that like, what better place? There's a better place that doesn't include me, and why is she not taking me? And so generally speaking, plainly and lovingly to kids is the way to go, and reading their capacity to hang in there. So that's one comment here. But in terms of this situation you're referencing, a couple of things to keep in mind. There is a field, a discipline called child life specialist, child life service. This is training, master's level training in childhood development and helping kids navigate illness or helping kids navigate the illness of their parent or family member. So one thing to consider is reaching out, asking around in that health system, is there access to child life services? That could be very, very important. That would be one thing to consider. Another thing to consider would be talking with this young person's teachers, making sure they're aware that she's going through some extra stressors at home and keep an eye out for her in school. Oftentimes the school will have a counselor, someone that she can check in with. If not, considering a psychologist for the 12-year-old can be helpful too. The idea is to establish some safety for this child. And when so much is falling apart around her, she needs to feel safe. And so those are some basic ideas. Lastly, I would say it may be helpful if the mom, you can imagine the torment, wanting to be with her daughter, but knowing that at some level it hurts her daughter. So alternative modes of communication, maybe not making the daughter be with her in person in the room so much, if that's not what she wants to be, but maybe rather writing letters, communicating through email or text, or a way that gives the kid a little bit of distance and may offer up a sort of a safety buffer. And then barring that too, writing letters to the kid for down the road. Because it's easy to imagine a 12-year-old when she's an adult looking back and saying, gosh, when mom was here, I wish I had spent more time with her. And if she can pull out a letter from mom that mom wrote before she died, you can imagine a solace that would bring a child who's going into adulthood. The key here is to navigate and minimize regrets. So there you go. There's some ideas.
Next question, are there any cultures that really do caregiving well that we could look to and learn from?
So cultures that do caregiving well, this begs some research. The answer is yes. There are cultures that take pride in caring for one another through aging and death and through illness, versus in the West, we tend to often outsource that. We'll be a little standoffish sometimes. We sometimes imagine that the person who's sick wouldn't want the help, etc. We find all sorts of ways to distance ourselves. So I don't know. I can't point. I know the answer is yes, but I don't have a lot of cultures to point to. I will say that here in Northern California, I am aware of a large Fijian population apparently in the Fijian culture, it is this is a point of pride and respect, and people take pride in caring for other people through illness and aging. So very often I've heard of families who are working with Fijian caregivers, and that has been a really wonderful experience. I would imagine that in Eastern cultures that there's more of a habit, more of a tradition of aging in place, where younger generations, whether from duty or desire or fealty, um, the expectation is that the adult would live with them in the home or whatever else. So I know that the answer is yes, but I would point you, I wonder if this would be a good question for Jillian, our librarian friend. We can think about that. But yes, the answer is there are other cultures that do this better than we tend to do in the West, but that's as much as I can say.
Okay. Next one is more of a comment that I think you will have a response to. So just wanted to read it out loud as it was requested during the original webinar. And it just says, component of witnessing is listening, a basic skill of companioning of ministry.
Yeah, yes. In other words, not doing things. Bearing witness often has so much to do with listening, sitting there, being attunement. Yes, listening, not saying, not doing, not pushing, etc. Yeah, and there is a spiritual, there's a holy overtone to it. It is, it's foundational in that way.
Okay, next question. From the experience of being a primary caregiver for my young daughter's 20-month journey with ALS, I was surprised at the amount of PTSD I experienced. I wish I had been aware that I might experience PTSD, which I actually call PTSG, G for growth, love that. How can I raise this PTSD aspect with participants in our caregiver course without instilling unnecessary fear?
So we know this, so data will tell us this in certain settings and certain illnesses and certain trajectories that there's some dangers, there's some real risk associated with caregiving, real health risks. And one of them is PTSD, post-traumatic stress disorder. And I love the question, the comment about post-traumatic stress growth, PTSG, because that's what can happen with trauma when processed with proper support and attention. That crises often lead to growth, but they need time. You need time, and you need support to do that. So, but in terms of preparing people as they head into caregiving, I feel you. You don't want to sort of, before they've even started the role, scare the hell out of them about talking about PTSD, et cetera, health risks. I think the basic point is you simply say that caregiving is hard and it's beautiful. It will stretch you in ways that are uncomfortable, but from which you will grow and you will be a better person for it. That's all true. I think just laying out both sides of that coin, that and that also instills some caution from the get-go that caregivers need help themselves. So that's self-care, but also reaching out to others. I think that's the kind of mode you want to set with caregivers heading into the job. I don't think you need to scare them with talk of trauma per se, but to simply note that it can be very hard on a person. And the difference between being growing from a caregiving experience versus being bowled over by it has to do with taking care of yourself along the way, getting what you need, getting help from others too. I think if you sort of lay that foundation with folks, you won't scare them off, and you'll help them understand what they're getting into, and you'll also normalize the idea that caregivers need help.
Okay, next step. A friend of mine shared an observation. It is rare for someone to change their behavior as we get older. We become more ourselves. I'd love to get your perspective on this. I take it as a warning. How might I help my aging loved ones become more of their best selves? And for myself, how might I become more of the person I hope to be, my best self?
Yeah, so there's phrases like can't keep teaching old dog new tricks. In the hospice world, we'll often say, and we mean it, that people often die like they live. In other words, how our basic natures are often set pretty early. And if I was a cantankerous person through my life, I'll probably die cantankerously. In this way, there's some constancy throughout. But there's also these moments of transition and transformation and change, especially if you're seeking it. You know, as part of it's a perspective, an attitude, a mindset, that aging can be a process of becoming, of losing things and gaining other things. Um, and it's a very, in other words, a very dynamic process. So, but you bring those intentions to the mix, pick what you want. I think one of the great questions that we ask each other in this realm early on is, what do you hope for? Where do you want to go? And sometimes I'll ask, how would you like to look back on this period? How would you like to have handled it? That can be a way for people to prime people to look for opportunities for change, for growth, for learning. Um, and sometimes I'll just simply ask, if I'm dealing with a client, I can simply say, you know, are things that you'd like to become? Let if illness is going to strip you bare, where do you want to go? Just in the developmental arc of your life, sometimes it's just simple as reminding people that we get to develop all the way through to the end, even as our bodies are crumbling, socially, emotionally, spiritually, we can keep growing. So sometimes it's simply as naming that and asking what you might hope for, where you'd like to grow, and sort of bringing that intention into the mix, and checking in on those wishes over time can be really wonderful and very enriching.
Okay, great. Next question. Is the caregiver as important as the patient?
I'm laughing because I know who's asked this question. Is the caregiver as important as the patient? The short answer is yes. I think we get into trouble if we start with our vertical thinking, our hierarchies. If we say person's more important than that person, we pretty quickly get into trouble. And usually the vagaries of language and our own mind trying to keep things simple or clear. So on the one hand, no. In the same way that this is a team sport, caregiver, caregiver receiver, we need each other. This is really a round table. So yeah, in so many ways, the caregiver is just as important as the patient. It also depends on the moment and the situation. There are moments where the caregiver really is there to serve the patient's wishes, and sometimes that needs to go the other direction. So I'd say that's a dynamic that at any one moment in time, the person whose needs are ruling the roost will shift. And a healthy dynamic is that's a movable dynamic that changes one day to the next, 1 hour to the next, depending on the situation. But I guess in the narrow answer to your question, yes, I'd say the caregiver is just as important as a patient.
Okay, and our last one, it's not a direct question, it's more of a comment that I'm hoping you can comment on. My question and comment have to do with the person who is the recipient of the care. It is easy to care for and love those who themselves demonstrate grace and behave in ways which continue to exemplify their gratitude for the care and their appreciation for the level of care they are receiving. But many people do not have those qualities. I think it is understandable for caregivers who encounter difficult patients to have negative feelings and feel very conflicted.
Yeah, thanks for this good question. Yeah, all this sort of rainbows and loveliness and vulnerability and intimacy, and some of that can be almost euphoric. It can be so gorgeous, so tender, and people can be so beautiful when vulnerable. And people can be assholes, can be jerks. Excuse my language. We can get very irritable. We can be really moody. We can be mindless, thoughtless, overwhelmed, self-absorbed, distracted, you name it. So all of the above. I think what you're signing up for in the caregiving realm is, and what to protect as a caregiver is a full emotional spectrum for your patient, your person, as well as yourself. It's because otherwise illness narrows us down. Well, it narrows some things down, but keep an eye where it can expand us too. So part of the job here is keeping a huge emotional swath and letting it all in and being honest. I think so much of the benefits of caregiving come from the sort of brutal honesty it can enforce. And brutal honesty includes, yeah, some people I just like more than others. It's just an observation. I don't wish it that way. There's some patients, some clients that I just am naturally, I'm more attracted to, more drawn to. There's no shame in that. I think we get into trouble when we pretend otherwise. So sometimes that means showing up for a patient who's just being a jerk. Sometimes that's being patient and sitting with them through that period because they're just overwhelmed. And sometimes some of the most important moments I've had in this dynamic is where I call it out. Say, hey, you're being a jerk. Cut it out. I'm not here. I'm here because I love you. I'm not here as a servant. So sometimes it's really important to call that dynamic out, at least to yourself, to be honest, but sometimes explicitly. That's where growth happens. That's where the exchange comes back in, and asserting your authority as a caregiver of being a human being too. So there you go.
Great. Well, thanks everyone for watching and listening, and thank you, BJ.
Thank you, guys. See you next time.